Thank you, everyone, for joining us. My name is James Herlowski. I'm the marketing manager for ClearFlow, and we're very pleased to have Dr. Spencer Melby, cardiac surgeon and renowned authority on postoperative atrial fibrillation, for this third installment of our webinar series. It's ClearFlow's e-learning series. The title of this webinar is Post-op Atrial Fibrillation After Cardiac Surgery, Potential Pericardial Contributors. Again, we're very pleased to have Dr. Spencer Melby, Associate Professor of Surgery, Division of Cardiac Thoracic Surgery at Barnes-Jewish Hospital, as well as Washington University, and also a cardiac surgeon and Chief of Cardiac Surgery here at the VA in St. Louis. I will pass it over to Dr. Melby, and we will get going. So thank you so much for joining us.
Hi, thanks for joining us. This is Spencer Melby. I'm a cardiothoracic surgeon, and I've actually spent several years now studying postoperative atrial fibrillation. I'm delighted to give this little talk on some of the research that I've done, and I want to thank ClearFlow for sponsoring the webinar, and we'll go ahead and just jump right in and talk about some of the work that I've done and some of the work that's been done by others and how we might go about preventing some postoperative atrial fibrillation. We're going to focus on what's going on in the pericardium. I have no disclosures for this talk. Postoperative atrial fibrillation is the most common complication that comes after cardiac surgery. And despite a lot of years of research trying to find out what the causes are, we haven't really changed the incidence of post-op AFib. And I'll show you some slides on that in just a second. We know that post-op AFib has problems associated with it. There's increased early and late mortality in several studies. Stroke is a problem, and we all know our patients stay a little bit longer in the hospital, and that drives up their cost. In fact, a few studies recently have shown that the cost associated with postoperative atrial fibrillation is somewhere in the neighborhood of $15,000 per patient. So they cost more for the patients as they just have to stay in the hospital longer. This is a study that we did right out of Barnes Hospital where we evaluated patients that came in over the course of 20 years, and we looked to see what contributed to postoperative atrial fibrillation. I'll just show you first the most important finding that I think is very telling, is that if you look at the 20-year period, you can see in this graph that all patients in the solid line or just cabbage patients in the dashed line, there hasn't really been a change in the incidence of postoperative atrial fibrillation in that 20-year period. It's right around 30%, and today, I'll tell you, our patients today, still about 30% of them have postoperative atrial fibrillation. So despite the advent of beta blockers, amiodarone, all the things that have been tried to treat postoperative atrial fibrillation or prevent it, we really haven't made a big dent in the incidence. This is a similar study, looked at 72 reports that said what their rate of postoperative atrial fibrillation. And you see that over the course of that 30 years, 35 years, the incidence of postoperative atrial fibrillation actually looks like it's gone up just a little bit. So we haven't really been able to, despite the research and despite new medications, we haven't really been able to decrease the incidence of postoperative atrial fibrillation. And that's probably because of what it says there in the very first point. We just don't understand very well what the underlying pathophysiology is of postoperative atrial fibrillation. We just haven't been able to say, here's the cause, and that's probably because it's multifactorial. A lot of things have been implicated, including inflammation, and right now inflammation is maybe the number one hot topic that's being discussed and being investigated, why inflammation contributes to postoperative atrial fibrillation. But other things, autonomic dysfunction, that's been looked at, the cardioplegia that's used in heart surgery, the dynamics of the atrium itself, if it's swollen or stretched, the renin-angiotensin-aldosterone system has been implicated, and then postoperative bleeding has been a consistent risk factor for postoperative atrial fibrillation. We're going to talk a little bit about that here toward the end of the talk as well. When I first started looking at this, I was at the University of Alabama at Birmingham. At UAB, we looked at about 1,500 patients that had undergone CABG or valve surgery. These are patients that had not had a history of postoperative atrial fibrillation or a history of preoperative atrial fibrillation, and we evaluated them for postoperative atrial fibrillation. We did a statistical analysis, a type of analysis that hadn't been done before. This is a time-related parametric hazard analysis. We essentially were trying to find what role time played in when patients had postoperative atrial fibrillation and how that was risk factors specifically tied to post-op AFib. This goes beyond just doing a typical Kaplan-Meier or a Cox regression or a multivariable analysis. This hadn't been previously described, and I'll just show you our main results of that study. If you look at the blue line on this slide, that is just a typical Kaplan-Meier estimate for freedom from postoperative atrial fibrillation. You see that at the very beginning you have a kind of a steep drop, and then it levels out, and then it drops again, and then it levels out a second time. If you do our hazard analysis with time, what that comes out to show is that there are actually two distinct time periods when patients are at the highest risk for postoperative atrial fibrillation. That parametric model there shown in the red line shows a very steep drop in the risk, but at the very, very beginning, after patients come out of the operating room, they have a very high risk for post-op AFib. Then they have that drop down to day one, but about the time 48 hours later on day two, they have a second peak of risk for postoperative atrial fibrillation. If you take that red line and break it down, you can actually show that there are two separate distinct phases for risk of postoperative atrial fibrillation. The first phase is that one I described coming right out of the operating room. It drops off quickly. It's probably related to what happened in the surgery. The second phase is the one that we tend to focus on, and that is the risk that patients have. Around day two, it seems to be the peak risk for postoperative atrial fibrillation. But you see they're still at risk at day 3, 4, 5, 6, and it goes out. The risk tapers off. But these two distinct phases say to me that there may be a couple of different things going on causing postoperative atrial fibrillation. So we did a multivariable analysis for each phase, and we found that the first phase had a couple of different risk factors than the second phase. The age at the time of surgery was a risk for both phases, and that's very well described and well known. But the cross-clamp time and whether or not you had a mitral valve procedure were risks for phase one, where the weight at time of surgery or being Caucasian were both risks for phase two. What's important to me and what's the takeaway of this is that they're different risk factors for the different phases. That just tells me something different is going on in phase one versus phase two. And we are seeking and actively looking in our lab to find out what those risk factors might be. If you look back at the literature, a lot of risk factors have been named: age, gender, race, whether or not you have hypertension, previous atrial fibrillation, redo surgery, congestive heart failure, valve disease, left atrial enlargement. The greatest of all these is age. Patients who have increased age or over 70 have an odds ratio of 5.6 in one study. And that, I'll just show you another slide of that. Essentially, the older you get, as shown in this graph, your estimated probability of postoperative atrial fibrillation goes up, where after 70, it's up to 40%. After the age of 80, it's over 50%. After the age of 90, it's 65 to 70%. So the older you get, the higher your risk of postoperative fibrillation. There's something underlying in the atrium that's contributing to this. So we can't really undo age, but there are a lot of other predictors of post-op atrial fibrillation that maybe we can have an impact on. Here's some preoperative risk factors, some more: chronic obstructive pulmonary disease, peripheral vascular disease, renal insufficiency, obesity, left ventricular hypertrophy, right coronary disease. These are some things that play a role in post-op AFib. But we also know that some things that happen postoperatively give you an increased risk for postoperative AFib. If you have a myocardial infarction, that increases your risk of post-op AFib. If you have congestive heart failure that's just being difficult to treat, those patients tend to have more AFib after surgery. Respiratory failure and infections, those are contributors. Renal failure, cardiac arrest, and then hemorrhage. The last one on the list we're going to talk about a little bit here, and my research has actually gone down that pathway to some extent, that there are certainly some things that happen if there's blood around the heart. It seems to be a contributor to postoperative atrial fibrillation. So let's explore that point just a little bit. In that same study where we looked at 20 years of history of patients at Barnes Jewish Hospital, we found, if you look down here in this bottom, it's outlined in a little red box, that patients that had to have a re-exploration for bleeding, they had a higher risk. In fact, their odds ratio was 1.72 of having postoperative atrial fibrillation. That just tells me something's going on. If a patient has to go back to the operating room for bleeding, they tend to have more postoperative atrial fibrillation. Then what is it about that ongoing hemorrhage that that may contribute to postoperative atrial fibrillation? And that's a question that we asked and investigated in the lab, and I'll show you those results in a second. This is another study that shows something similar. This came out of London. This is a study, out of Liverpool, out of England. This is a study that looked at patients, over 17,000 patients. They looked back 10 years of patients that either had isolated CABG or had an aortic valve replacement in CABG, and looked to see, okay, who had postoperative atrial fibrillation. It turns out that if you had an isolated CABG and you had to have a re-exploration for bleeding, then that was statistically significant, that you had a higher rate of post-op AFib. And they just did a measurement of how much blood was drained into the chest tubes after surgery. If you had a higher rate, 800 cc's of blood versus 720 cc's, then that was also a predictor of postoperative atrial fibrillation. And that was true for both patients who had lone CABG or had an AVR plus CABG. And you see them highlighted here around this little red box. But essentially, it almost doubled the rate of postoperative AFib if you had to be re-explored for bleeding, or if you had a higher rate of bleeding in your chest tubes. They were both predictors of patients who had post-op AFib. So it seems that something about the blood in the pericardium plays a role in who has postoperative atrial fibrillation. This study came out of the Cleveland Clinic where 12,000 CABG patients, these are patients who only had coronary bypass grafts, they looked at 12,000 patients over a 7-year period. This actually was a study. They were focusing on who had to have transfusions and what the different morbidity associated with transfusions were. But one of the morbidities that was associated with transfusions is postoperative atrial fibrillation again. So the patient that were not transfused had a much lower rate, almost half the rate of patients who had to have a blood transfusion. They had very low rates of post-op AFib, but it went from 4.9% up to 7.8% in those that did not have a transfusion versus those who had a transfusion. So it seems that patients that were bleeding and required blood, those patients had a risk for postoperative atrial fibrillation. So we started this study where we said, is it something to do with the blood in the pericardium? Is there some contributor to postoperative atrial fibrillation? So we set up a study. We have access to the fluid around the heart, and this is what we did. And this actually is an ongoing study we're still doing. It's funded by the VA. We have a grant, and we've looked at over 100 patients now. Essentially, this is what we did: is we captured the pericardial fluid from patients. First of all, when we started the surgery, we drew a pericardial fluid sample then, and then when they hit the ICU, we drew blood out of the pericardial fluid at hours 4, 12, 24, and 48. So we now have 5 samples of pericardial fluid pre-surgery, and then for these 4 time points after surgery. We also checked the blood levels of these things at those same time points. Then once we had the fluid collected, we could go back and look and see, okay, what's in this fluid that may be contributing to postoperative atrial fibrillation? We looked at a whole host, over 30 different cytokines, all these different interleukins, TNF-alpha, interferons, and others, and said, okay, what seems to be contributing to postoperative atrial fibrillation? We also did some spectrophotometry on the fluid and mass spectrometry. So first of all, here's the flow cytometry. This is an example of a patient when their baseline intraoperative cell population was measured by the presence of CD14 and CD16. These cell types that showed up here are largely monocytes, and what you see highlighted in the box, this would be who we would look at it being our PMNs. There are hardly any when you start the surgery, but within 4 hours after surgery, the monocyte population disappears, and you have this huge influx of PMNs at 4 hours, 12 hours, 24 hours, and 48 hours. You start to get some monocytes back about 2 days later. But this is a neutrophil riot, is what one of my inflammatory specialists called it. The neutrophils show up in the pericardium within 4 hours, and there are huge numbers of them, and they stay present all the way out to 48 hours. At the same time, we measured these high level of neutrophils showing up in the pericardial fluid that were not there prior to surgery. You also see a very high level of the cytokines, which you would expect to be present with those cell types. So these 4 little graphs show what the levels of interleukin 6, interleukin 8, TNF-alpha, and MMP9 are in the pericardial fluid, which is the solid line with the box on each of these 4, versus what the level of those interleukins are or cytokines are in the blood, which is this dashed line with the triangle. And you see that at hour 0, there's almost none. That's that's the time point of surgery. But within 4 hours, the cytokine level is 5 times higher in the pericardial fluid than it is in the blood. And here it is 3 times higher. And we found this consistently around a lot of inflammatory cytokines, that the pericardial fluid is much higher, has much higher concentrations of these inflammatory cytokines than the blood does. So this leads us to look a little bit further. Here's one of interferon alpha 2, same finding, only now we've looked at it just a little bit differently. We've looked at the pericardial fluid and we said, what about these patients that had post-op AFib versus those that didn't have post-op AFib? Now, this is one of our preliminary evaluations, but of these patients that did not have post-op AFib are in the circle with the dashed line, and if they had post-op AFib, it appeared that the levels of this interferon alpha-2 were higher in patients who had post-op AFib. And then we looked specifically at the oxyhemoglobin and the methemoglobin concentrations in the pericardial fluid. Now, oxyhemoglobin, methemoglobin, these are both red blood cell breakdown products. If you take a red blood cell and allow it to burst and die, then you have hemoglobin, and the body and PMNs specifically will oxidize those molecules and turn it into oxyhemoglobin and methemoglobin. Well, oxyhemoglobin and methemoglobin are potent oxidizers themselves, and so we look to see what about the level of oxyhemoglobin and methemoglobin in the pericardial fluid, and might that play a role in postoperative atrial fibrillation? It appears that the patients that have post-op AFib, which is the dark line with a filled circle, have a higher level of oxyhemoglobin versus those that don't have post-op AFib. But what we found is those with methemoglobin, this was statistically significant at both 4 hours and at 12 hours. This lower line with the filled circle is patients that had no post-op AFib. This higher line is with the open circles of the patients that had post-op AFib. And we found a statistically higher level of methemoglobin in those patients who had post-op AFib. What this tells to me is that blood in the pericardial space is not good for the heart. This oxidized blood breakdown product is associated with post-op AFib. And if we can decrease the levels of methemoglobin in the pericardial space, then we potentially can decrease the level of post-op AFib. And we know the cytokine levels are very high in the pericardial fluid. We know that the methemoglobins are higher in those that have post-op AFib. So what can we do about that? So now I'm going to shift gears a little bit as we wind down the webinar. I'm going to just talk about chest tubes and what role they might play here in postoperative atrial fibrillation. Here's a picture of some chest tubes that anyone that's ever done cardiac surgery has seen pictures like this. When you pull the chest tubes out of patients, it turns out, and this has been studied, about a third of the time the chest tubes are occluded with blood clot. And that's very common. We've all pulled chest tubes out and seen a big string of clot in them. And here's some pictures showing just that. And if you cut a chest tube in half, you can see it's occluded with blood clot. Well, a study that came out of Cleveland Clinic, they looked at 100 patients and they said, well, let's just pull the chest tubes and let's evaluate them. Let's see what happens with the chest tubes. They found that 32 of the 100 patients had a clotted chest tube. But furthermore, they found those patients that had a clogged chest tube, half of them had postoperative atrial fibrillation, versus patients that had a patent chest tube, only 22% of them had postoperative atrial fibrillation. So just this little observational study, it's not surprising that a third of them have clogged chest tubes. We see that all the time. But what's kind of eye-opening here is that the rate of postoperative atrial fibrillation is less than half in those that had a patent chest tube versus those that had a clogged chest tube. So you look at this observational study and you couple that with the finding we had, patients had a higher level of methemoglobin. I think if you leave blood products and blood breakdown products in the pericardial space, I think you're contributing to postoperative atrial fibrillation. So these chest tubes with the active clearance technology have been studied in several studies. And here's a nice one that was done by Teddy Fischlein in Germany, where they actually looked carefully at patients before they instituted the active clearance technology chest tubes, and then after. So you see this graph here actually shows 3 phases. Phase 0 is before they ever did anything. This is just their baseline. They have patients, 543 patients out of their 1,800 had post-op AFib. That's about a third of their patients had post-op AFib. About 20% of them had retained blood syndrome of one type or another, where they found that there was more blood in the pericardium or in the lung space or something. After they instituted the active clearance technology, the amount of patients that had postoperative atrial fibrillation went from 29% down to 20%. So they knocked it down by about a third. And the patients who had retained blood syndrome went from 20% to 11%. So they found a significant decrease, so statistically significant, in the amount of postoperative atrial fibrillation they found. They said, well, we just want to make sure that this isn't just because we're paying closer attention to it. So then they actually went back to using the same chest tubes they were using before and took off the active clearance technology, and that's phase 3 here, and their post-op AFib rate went back up. It's not different from phase 0 from phase 3, although it went back up in such a manner that they felt, yep, it appears that the chest tubes themselves were contributing to the reduction in post-op AFib. And you see the retained blood syndrome went back from 11% up to 18%. So that study was done in Nuremberg is promising, and I think it corroborates a little bit of the study that we had of having methemoglobin in the pericardium being a risk factor for postoperative atrial fibrillation. So if you look at this study and you say, well, what can I do for reducing postoperative atrial fibrillation? I'd say there are some things we can't help. We can't change the patient's age. They show up whatever age they are. We can't really change their preoperative risk factors. But one of the things we can do is we can reduce how much blood is in the pericardial space, and that's by simply keeping an actively patent chest tube. Make sure the chest tube is doing the job that it's supposed to do. I mean, we put it in there for a reason. And if you can do that, you can reduce the postoperative atrial fibrillation. So to summarize, here's a little cartoon. He says, it's fine to discover cures, but remember, chronic conditions are our bread and butter. It's just kind of funny to me. We don't want to be the scientist that doesn't cure things. We actually want to help our patients. So we want to get rid of postoperative atrial fibrillation if we can. It's hard on our patients. They have higher morbidity, mortality. They stay in the hospital longer. Just if we can reduce this complication, then we should do it. There's a lot of factors that likely are contributing to postoperative atrial fibrillation. And a lot of those factors we don't really understand that well. We know some of them that we can control, some of them we can't. Inflammation is probably one that we can reduce. The studies that looked at steroid administration, they pretty consistently reduce postoperative atrial fibrillation. The problem is none of us surgeons want to give our patients a big dose of steroids to reduce the inflammation. Well, maybe another way we can do it is the inflammation that's related to just having blood around the heart. And if we can reduce the amount of blood and blood breakdown products that are in the pericardial fluid, we might be able to reduce postoperative AFib. It seems to be a promising avenue. The studies are looking very promising. Those people that have looked at this carefully with this active clearance technology have had great results. I think that we can just summarize all these findings. If we can reduce the retained blood and the blood breakdown products in the pericardial space, we can reduce postoperative atrial fibrillation. I want to thank everybody for tuning in. Thank you for your attention, and I'm going to pass off now. I'm happy to answer any questions that anybody might have.
Thank you again so much, Dr. Melby. Incredibly informative, and thank you so much for sharing a lot of your findings there with us. Just a couple questions that did come in. One is basically, in your opinion, and you may have already answered this, I think you may have, but in your opinion, what would be the current most effective method, or a combination of methods perhaps, to try and minimize or prevent post-op AFib after cardiac surgery? Again, I think you may have mentioned this, but I don't know if you'd like to try and address that question.
So it's a question it's a challenging question, actually, because we don't really have anything that's that effective to reduce postoperative atrial fibrillation. The medications that I'm thinking of, amiodarone, beta blockers, everyone pointed to that and said, well, if we can get our patients on beta blockers, we should be able to reduce postoperative atrial fibrillation. It turns out that in the big studies with hundreds of thousands of patients that the STS has published, the beta blocker patient population actually has a little bit higher risk of postoperative atrial fibrillation. And despite several studies showing that amiodarone, if you administer it before surgery, during and after, that they'll have a lower rate of post-op AFib, it just hasn't ever been that effective, and it's not become mainstream use because you don't see a huge effect. Now, we still treat patients with amiodarone, and it seems to help. But I showed you, despite amiodarone, we still have the same incidence of post-op AFib. Now, this active clearance technology, chest tubes, I think that we're going down a pathway that actually we can mechanically keep our chest tubes open, and if we can keep the blood breakdown products from rubbing up against the atrium, I think we have a chance to reduce post-op AFib. I don't think we're going to get rid of it. This isn't a cure for the disease, but I think it has the potential to reduce the levels of patients that we see with postoperative atrial fibrillation. And that's a step in the right direction.
Thank you again, Dr. Melby. Another question that just happened to arrive was basically with regards to all of your different research, because we know you have done extensive research, not only with post-op AFib, but with other arenas as well. Is there any one thing that stands out that has been sort of the most surprising or most unexpected findings that you've uncovered throughout your research?
Well, I didn't have enough time to show you all the findings of the cytokines, but we looked at over 30 cytokines in the pericardial fluid, and the finding that wasn't surprising was that it was different than the blood. But what was surprising is that sometimes it's 5 or 10 times higher in the pericardium than in the blood. So the inflammatory cytokines and markers in the pericardial fluid right after surgery, they're sky high. And if you look for them in just the blood, which is what most people have done in the past, they do go up. But if you look for them in the pericardial fluid, they go through the roof. So that's one of the really exciting things that we found is, hey, maybe this little compartment right around the heart, maybe it's playing a larger role than what's going on in just the blood. The blood circulates through the whole body, but the pericardial fluid, it's just around the heart. We also have had some more exciting recent findings that we submitted to and have had accepted at the AATS. So if you come to the meeting of the AATS, you'll get to see our most recent findings. We found some more markers of what increases postoperative atrial fibrillation in the pericardial space. And we'll be presenting those findings soon, and then we'll have those published as well. And it just adds a little bit more substance to the notion that the pericardial space is important in what generates postoperative atrial fibrillation.
Again, thank you so much, Dr. Melby. And you actually you preempted my last question. I was going to be so self-indulgent to ask you if you had any little nuggets you could share with us as far as your upcoming presentation at the AATS in Toronto. So I guess we'll stay tuned for that and definitely come back and look forward to that. So again, thank you so much. Thank you everyone for joining, and make sure to also stay tuned for the upcoming next series of the next installment of our webinar series, which will be coming up soon, and it will be by way of Dr. Mark Gillenoff from Cleveland Clinic. So definitely stay tuned for that, and we will definitely let you know when that is on the rise. So thank you again, and have a great day. Goodbye.